Yeah, so mantle cell lymphoma is a difficult lymphoma. It's aggressive disease. Most of the treatments we've got frontline for elderly or young patients work relatively well. Patients frequently go into remission, which can be quite durable. But when they relapse, it's quite difficult to get people back into remission, and whatever remissions you get are often short-lived. So from relapse, the median survival is 1 to 2 years. So the challenge is finding effective therapies for that group of patients. Well, it depends a bit what you've got access to, but broadly speaking, frontline patients will receive rituximab chemotherapy. Be that in a younger patient, that will be more intensive style treatment, usually consolidated with a transplant. In elderly patients, that will be rituximab chemotherapy, and there are a range of chemotherapies that one can use. At relapse, then what tends to happen is you tend to use an alternative chemotherapy regimen with or without rituximab. There are 4 licensed drugs in the world for mantle cell lymphoma: lenalidomide, Velcade, ibrutinib, and temsirolimus, which is only available in Europe. And you may or may not use one of those drugs if you have access to it. I have to say, just to anticipate your question, temsirolimus, even though it's licensed in Europe, is very rarely used, largely because it's intravenous and it's weekly, and it's quite difficult and quite expensive. So whilst that was the comparator in this trial, that was largely dictated by the regulators, because in Europe it was the only licensed agent. Okay, so the RAY trial was a randomized trial for patients with relapsed mantle cell lymphoma. It randomized between temsirolimus, which is a mTOR inhibitor that's available in Europe and licensed for patients with relapsed refractory mantle cell lymphoma, against ibrutinib. So both drugs were given to progression or unacceptable toxicity. It was a 1-to-1 randomization, and the primary endpoint of the trial was progression-free survival. There were a number of other endpoints, including quality of life, but what was presented today was progression-free survival and overall survival and toxicity data. The rationale was to essentially that there haven't been any randomized trials against ibrutinib. And so this was a straight randomization against a licensed therapy. It was a trial that was required by the regulators in Europe for the drug to get a license. The phase 2 single agent data was so good, it actually got a license based on that, but there's always a requirement for a confirmatory trial with a randomization. So in a sense, the trial was designed and run with the intention of getting a license for the drug in Europe. Well, the first thing to say is the progression-free survival for the temsirolimus arm was 6.2 months, which is the best progression-free survival ever seen with that drug. And if you consider that to be a poor comparator for such a study, that's on a par with bortezomib, Velcade, which in the American registration study had a PFS of 6.5 months. And lenalidomide actually has a PFS of 4 months in the registration study in Europe, so it's on a par with those. So that was the temsirolimus. The ibrutinib arm PFS was 14.8 months, so it's more than twice as good. Highly significant. The other thing just to say is the length of time patients were on the 2 drugs. The patients were on the ibrutinib more than 4 times as long as the temsirolimus, and despite that, the serious adverse event level was less. So despite massively longer exposure to drug, there were fewer side effects. Tolerability. So ibrutinib is an extremely well tolerated drug. It's oral. From a hematological perspective, it very rarely causes significant hematological toxicity. There's some neutropenia, but it's modest. Non-hematological toxicity, the commonest side effect's diarrhea, which in practice is almost always grade 1-2, very modest. Patients actually don't tell you about it unless you ask. Rarely requires any kind of pharmacological intervention. So not the kind of diarrhea that one sees with the PI3 kinase inhibitors with colitis. Temsirolimus is intravenous, it's weekly, and it does cause significant thrombocytopenia and also neutropenia. So that has a different side effect profile. And also you get some pneumonitis, that's an mTOR class effect. So if you compare ibrutinib with chemotherapy, it's far better tolerated, of course. There's no alopecia, as I say, modest effect on counts. Patients generally feel very well. One of the problems, I think, with ibrutinib is that you've got to be patient with it, because the response can take a while before it's significant. So it can take, for example, up to 9 months before you get a partial remission. If you look too soon, you'll think the patient's not responding. However, the patient feels great, so you need to stick with it. The answer is it? Well, the question is it comparable with chemotherapy? Of course, it isn't from a side effect point of view. The question is it as good as in a trial? And there's a trial that I've just opened in the UK. It's a UK IIT, which is comparing ibrutinib with rituximab versus bendamustine with rituximab, so a straight randomised trial between chemotherapy and ibrutinib. And I guess that ultimately will tell us whether it's going to replace chemotherapy or not in the frontline setting. So I guess the result of the trial is a no-brainer. I mean, everybody could have predicted that ibrutinib was going to beat temsirolimus, so the PFS is not a surprise. The thing that is the big surprise, and this paper is now published and this evidence is not in there, but I presented it today, is if you look at response and duration of response in the ibrutinib arm, you see a very impressive difference in progression-free survival if you use the drug earlier. So if you look at response rate alone, if you use ibrutinib after first line, after second line, after third line, after fourth line, the response rate is identical. So lots of people are happy to use ibrutinib later on because you are pretty confident you can rescue the patient. What we did in the analysis for this study is we looked at progression-free survival with exactly that same scenario. And what you find is if you use ibrutinib as the first relapse drug, you get an extremely impressive PFS. So 65% of the patients have a PFS that seems to be, it's a flat line at the moment. I'm sure that won't continue, with 20 months median follow-up. If you use it later on, it's nowhere near as good. So that's the first evidence that suggests that you should be using this drug earlier rather than later if you've got access to it in the relapsed refractory setting. Yes, I mean that data showing you should use it earlier in a relapse setting, obviously the next step is should be using it frontline. And as I said, we've got a trial that's just about to open, it's just opened in elderly patients, asking that very question. So that's the natural thing. And in CLL, some of the data being shown today, in fact, shows, again, if you use ibrutinib single agent frontline, you get some astonishing results in CLL. So I think all the evidence is pointing to earlier use of the drug equals better efficacy. The other thing I should say is one of the concerns about ibrutinib, and that's based on some of our, including my own anecdotal experiences, is when patients relapse, they're often very difficult to retreat. That is true when the patient's already received 3 or 4 prior lines of therapy. When it's much earlier on, like in the Ray trial, patients were able to be retreated just as much in both arms. So I think earlier treatment with ibrutinib doesn't look like that creates problems when patients relapse. But again, we need more evidence just before we can say that for sure.